Welcome, I'm Nick Bansback. I'm a scientist here at Chaos at St Paul's. I'm also the co-lead for the Health Economics and Simulation Modelling Methods cluster at the BC Support Unit. And as part of that, we're trying to encourage the community of health economists across BC, and in particular to be working together and to be thinking about how to do patient-oriented research better. And so when we heard that Paula Lorgelly is in town, she's here to help Genome BC on a project that our friends at the BC Cancer Agency are working on. I see someone in the audience. We thought, let's get her to come and give the work in progress at Chaos at the same time. So Paula is currently at the Office for Health Economics in London, and she's previously been at Monash in Australia and a few other places, but she is going to give us a great talk on does the public value targeted sequencing in advanced cancer. So thank you, Paula.
Thanks. Thanks very much, Nick. I'd like to say thank you for the invitation, but I in fact invited myself. So hopefully, so this is not patient-oriented work. The public is in the title, but hopefully there is some patient stuff in there. It's also health economics, because I'm a health economist, so it does a discrete choice experiment. So can I just get an idea of, not that I'm going to change my pitch right now because I'm not that much of a seasoned presenter, but how many people in the room are health economists? Okay, how many people know about genomic sequencing? Well, that's probably more than I know. And how many people have just completely new and in fact you just turned up for lunch? There's a lot of people here, that's great. Okay, so this is work that I've been doing with a colleague, Grace Hampson at OHG, James Buchanan, who is actually our DCE expert on the, so any questions you've got, I will field them to James, or in fact we do have DCE experts in the room in terms of Nick and Dean, so I might redirect any questions back to them unless they come from them, and then I might just glare at them evilly. And my colleagues at Melbourne Genomics Health Alliance, so they're based in Australia. So this is a kind of a long-standing relationship that I've had with them. So that's something about doing health economics, if anyone needs any encouragement, is that because, as Nick was just saying to me privately, there's more demand than there is supply, so you get long-standing relationships. And so the good thing about this, I haven't been in Melbourne for 3 years, but I have long-standing projects with them, and now I get to go to Melbourne at the end of this month funded by them, so it's always great to do that. And then I get to go on to New Zealand, which is where I'm from originally, so somebody gets to pay for my holiday as well, or at least my flight. So I'm doing a little spoiler. So does the public value targeted sequencing in advanced cancers? Well, yes, they do. Of course they do, because that's the way that we've designed the experiment, which is something that Dean was, I was reflecting with on Dean about some of the stuff that we look at, whether we would actually stand by what we've found in a kind of scientific way. So yes, they do, because that's how we designed it. But I think what's most interesting is that what we're interested in is how they're trading off the different attributes or the different elements of genomic sequencing that we'll go through. So to give you some background to this, so this is funded from the Melbourne Genomics Health Alliance, so they have a large amount of money, not unlike Genome BC. And it's the solid cancers flagship, so somewhere there'll be another flagship specifically on leukemia and those cancers. The flagship's called iPredict, which again is one of these quirky things in science where it's not really an acronym because they've just picked some letters out of a long title that make a word. So it's incorporating complex profiling of patients to enroll into molecular directed cancer therapies. And so that's effectively what iPredict does. And so it aims to generate evidence to inform the implementation of genomic medicine. They want genomic medicine, they want to keep getting funded. I'm a little bit more sitting on a fence in terms of understanding whether they should be funded, because clearly we can use that money for other things. We only have finite resources. But they want to think about how do you implement it into clinical care. So there's a whole range of clinical studies that are going on, collecting data from patients, doing genomic sequencing. But the health economics component specifically is going to assess the cost effectiveness of it. So looking at how much it costs to deliver genomic sequencing within a group of patients. And we're looking at preferences for sequencing. And we're going to try and use that evidence, and it's a question I'll come back to at the end, on how this then informs the implementation into the wider healthcare system in Australia. And, you know, if you do it well, implementation of it internationally. So the objective of this specific paper is to elicit the public's preferences for different features of a genomic test. So there is some ongoing work where we've actually involved patients. And as you might expect, it does take a long time to recruit patients into this sort of study. So we decided that we would get some early wins by looking at the public. And so we designed an experiment or a survey for the public. It will actually allow us to later think about whether the public and patients value these things differently, which is interesting as well. And essentially, we'll be looking at the relative preferences of different attributes and how then we'll use that to determine value and inform kind of a technology adoption and service design decisions. So, you know, there's kind of faceless group of decision makers down the bottom. That's kind of effectively who we're trying to inform with this sort of work. So we looked at the current evidence base because that's what we do as scientists, and we searched for literature and preferences for genomic tests, particularly in relation to cancer. We were interested in both the patients and the public. So we did a search that completed in May. We probably need to update that now, particularly as I'm about to write this up as a paper. Of course, I don't want to find a paper that's going to tell me something I don't want to know, because it would mean that my design is out. But it's one of the quirks of this area. So we identified 10 papers, 4 specific to cancer, and none had been done in the Australian setting, which doesn't surprise me. There were 2 that were most relevant. Unsurprisingly, one of them was my co-author James Buchanan's work that he's done on CIL, and another one by a Canadian who I'm not going to pronounce, and I'm hoping they're not here. But does anybody know that name? Yes. Yeah, is it medical? Well done. He's not here. Okay. It's okay. I don't say anything bad. It's also being recorded. It's a brilliant paper. I'm not going to say anything bad about it. So preferences for attributes of hypothetical or actual genomic testing. So there's the papers. What you can't see that because the font is way too small. I can barely read it up here. But James's design in the first row looked at time, the cost, how good the test was to predict who would respond to different chemotherapy treatments, the reliability, length of time, and the type of clinician who explains the result. And I think most interesting is the kind of conclusion that you can see over on the right-hand side. And also, when I was reading this to myself this morning, I was thinking, well, that's a no-brainer. Patients prefer tests that are more effective. Well, I would. Are more reliable. Well, yes. Cheaper. And which return results quickly. But I think what's most interesting is that they prefer to receive them in a 15-minute appointment. It's not always known how long an appointment should be. You don't want to spend a day, you know, with a consultant where they explain something to you. You might not want to spend an hour, and so there will be some issues about how long you spend. And they wanted to spend it with a clinician who's an expert, which might be another aha kind of moment. Although that clinician who's an expert might not be your usual oncologist, and you do have a rapport sometimes with your usual oncologist. And then what they found was that future genomic testing was associated with a higher utility, a higher preferences than current genetic testing. So there is current genetic testing in the UK, but what they proposed was something that beyond that, and it was apparent that the ideal, or what they proposed as the ideal, was more preferred. And then the other one, whose name I'm still not going to be able to pronounce, then had a hypothetical genomic test with the general public and also with a small sample of patients, and looked at untreated responders, unnecessary treatment, severity of side effects, likelihood of side effects, test turnaround, test procedures, and test cost. Found that severity, likelihood, and the way the test was performed, so they had options of being a mouth swab versus being a blood sample versus being a biopsy, they influenced the public's decision on their preferences. And then the sensitivity of the test had a large influence. Interestingly, what kind of led us down the route of doing patient preferences versus public preferences is that he found that the patient and publics had different perceptions of various aspects. So, which kind of comes into the paradigm of we care what patients think because we're living in an era where patient choice is paramount, but then we're using public funding, and so do we now, how do we sit with the fact that public preferences normally allocate, how we, what decisions we make. So I went down the route of doing a discrete choice experiment because that's what the rest of the literature was on. We did 12 choice tests of an unlabeled design, 5 attributes, which I'll show you in a moment. We had a D-efficient experimental design, which basically meant that had kind of good coverage of all your different options and your alternatives when you paired all these together. And we used priors from a previous design, that being James's, and then we actually updated that because we did a pilot of the survey, and then we updated our priors. We used an online panel, and we wanted half to have some experience of cancer because we thought that would be interesting to see if own experience or family experience actually changed what elements and what preferences you would have. And then the survey included questions on demographics and socioeconomic factors. So just so that you know that we did it well, I say we did it well, this is James doing it well, my co-author. We had a whole series of designs that we actually compared, and so we checked their efficiency. We looked for implausible choices, so are there combinations that come out with of different levels on the attributes that then just wouldn't go together. It's not in this, but I always use the example of if your design is about life expectancy and then improvements in life expectancy, you can't necessarily have it. It's implausible. An 80-year-old who then has an increase in life expectancy of 20 years, that would be an implausible design or a plausible option. We checked the level balance to make sure that there was enough of the levels were appeared in equal or as much as equal across the 12 choice sets. We looked for minimal overlap. We checked the probabilities that choices were not equal or strongly in favour. Checked for collinearity, and then we actually produced a sample data matrix that was then run through a multinomial regression to make sure that it would work. So that's what James did. So just to provide you for some people in the room that don't know, of course, we were dealing with the public here, and we needed to ask the public to decide on advanced cancer. So we had to tell them what advanced cancer was. So there was a lot of information at the start of the survey, actually telling them what they were making choices on. So, so just to highlight the bit that I've highlighted in bold there, explicitly says advanced cancer is a cancer that is unlikely to be cured, although treatment may still be available to slow its growth and manage symptoms such as pain. And so there was that, so they can make sure they weren't being too hypothetical. And then, of course, we also had to explain to them what genomic testing was as well. This is quite a cognitively burdensome experiment otherwise. And so this was the actual text. You might be amazed we still got people to fill in the survey, but of course we were paying them to fill it in. And then we talk about, the different tests, we talk about the DNA, and then the bit that kind of explains what it is. Tests are now available that may identify variants in the genetic makeup of a patient's cancer cell. This test is called a genomic test. So we take it as intrinsic that they've read this and therefore they understand what experiment or, their options that they're answering. And so this was the attributes of the DCE. So, and we worked actually with our clinicians. So this is, I've seen some DCEs that become implausible because actually as a health economist, you have no idea how the healthcare system works. And so I actually said, so I think we started off with saying, could we have 1 week turnaround of these tests? And they were like, well, yes, if we don't do testing for anything else. And this is the only test that we run through the pathology lab. So we went for a 2 week turnaround and then a 6 week turnaround, which I think is more common, which you might think is quite a long time when you've got advanced cancer. And we talked about the cost of the test to you from 500 to 6,000, and part of that was deemed for the fact that in Australia there is a private market for some of this, and so you can actually get some insight on what the cost should be. The likelihood that the test will lead to some change in treatment, so we had to explain that if you had the test, then there is either a 5 to a 25% chance that your treatment plan would be changed. The length of time that the health professional would spend describing the test to you. So that's not the results of the test, this is actually just explaining what the test does. It's kind of like an information attribute. And then the type of healthcare team who explains the test. So a specialist, a treating team, or a local treating team. So as you can imagine, actually Australia is quite like Canada, except Canada's obviously got harsher winters. But I'm thinking kind of geographically. So there are a lot of people that live in very rural areas, and so you can have a good oncologist, but you're not going to have it in a specialist cancer hospital unless you go and travel, say something like 6 hours to go and have that specialist care, which I'm assuming is the case in Canada, that you don't have kind of rural, massive specialist centres. So this was an example DCE, just so you can see what it looked like. So everybody faced 12 of these when they were doing the survey. And they just had to say A or B. And yes, we haven't included, before somebody asked, we didn't include an opt-out option. We wanted people to just tell us, you know, what their preference was. And I think that's partly because if this was, well, this DCE design was dominated by the ones we gave patients. And for patients, we didn't believe there would ever be an opt-out option. We always thought they would want more information and that they would never opt out of not having a test. And so we used the same design. And so this little iffy down here, which is moving, was me for days, trying to work out and solve the mixed logit that we ran and all the different options. So James has been really great in giving me the design, but at some point he obviously thought I needed to learn something. Learning by doing was a long process for me. I've done some DCEs, you know, if anyone's doing DCEs, never take a break from them, right? Because the methods move on too quickly. And when it comes back, you have to learn to kind of ride the bike again. So we did an iterative process. I did the iterative process of trying to work out the estimation process, given the AIC and BIC, which parameters in the model were going to be random or fixed, and then adjusted it for correlations, and then ultimately came down to what we were interested in, which is your marginal rate of substitution. So what's your willingness to pay for changes on these different attributes? And we could do that because we had time linearly in the model, and everything else was effects coded. So a quick idea of the sample. So one of the reasons we often do public-based studies is because you can get a sample overnight if you're paying enough money. Whether you get quality overnight is another question. But we had a 2-month window where we asked Cint, which is an online survey company, for a sample of 250 respondents. We got 254. We wanted half of them to just be the general public, but with a quota system, we wanted people to have, we wanted to make sure that we were sampling according to the age that was reflective of the age that people get advanced cancer. So it wasn't going to be representative of Australians' age, it was going to be representative of Australians with advanced cancer. We wanted to be representative of state, the state populations. And then we also then had half of the sample we needed to make sure they had a cancer experience as well. And so we have 254, of which 128 have some experience of their own cancer or a family sort of experience of cancer. And we didn't go into too much detail there. So there's the demographics. Again, it's one of these slides you can't read. And then I'm about to put some font up, which you might not be able to read either. So relative to the Australian public, they were older than the general public, but that was great because that's what we wanted, because we wanted them to be representative of advanced cancer patients in Australia who are older. They were more committed, whatever that means from someone who's not married, but there are a higher proportion of them were married. I don't know what that says about online panels. Maybe they do them because they are married. They want to get away from the marital situation by filling in surveys. They were more educated, which you do expect, I think, with online panels. And interestingly, Victoria, which is where Melbourne is based, the state that Melbourne is based in, was overrepresented. I don't know why that is, and Queensland was underrepresented. And so there's probably a province in Canada that is reflective of Queensland, where Queensland is a little bit more Hicksville. So you can probably think of you can, I'm not going to say it, a province in Canada that's similar, and about whether you also get underrepresentation when you do online panels in that way. And it's a massive state. Whether they've got broadband rolled out, whether they've got access to online panels is also questionable. Okay, so getting on to the actual results. So something we put into the survey was just an easy ranking question, just to see how they ranked attributes before they even got some experience of what the levels were in the survey. And so we asked them to rank them, and this is the ranking that they came up with. They said cost was most important to them, and then the time, how quickly the turnaround was for the test, the likelihood of changing treatment, the length of time taken to explain it, so the length of time they spent with their oncologist, and then who explains the test. We found that those actually had family experience. The only thing that happened there was the top two. So the cost and the time were equally most important. So there was some slight variation there if you've got some sort of history or some sort of own experience. We also did this ranking post DCE because we wanted to see, once you gave the respondents some more information and you gave them some levels and you got them to make choices if that changed, and it didn't. And I probably need to reflect a little bit on the literature, although maybe Dean and Nick can tell me afterwards if that's just the case. And in fact, despite the fact that you're giving them a really sophisticated survey, they still, stick to their guns and they still give those rankings. We had an informal test of rationality, which I'd like to think, was included from the start. I don't know why we have a whole email trail where suddenly we got back 13 choice responses in the survey and we'd only put in 12. It turns out the middle one by Quirk, I think it was a telephone conversation, never talk DCs on the telephone without anything written down. We'd put in a kind of dominant choice. So version A was the shortest time, the lowest cost, the greatest likelihood, the longest time spent explaining the test, and a specialist treatment team, although that's not true, that's necessarily dominant, versus a B option. And we found that 94.5% of the sample preferred A, so it kind of tested that they were rational, but we didn't chuck out the 5.5% who are deemed to be irrational. And that is following some work from Emily Lanskar and Jordan Louvier, who says, keep them in. So we kept them in for that sense. So again, a large table with small numbers for you that you can't read, but I've had to go with the highlighting pen so you can see what I'm talking about here. So these are the regression results, and so you can see that cost was significant and negative, which you might expect. So as cost goes up, their preference for it, declines. Time to get the result is positive. It means there's a preference for spending, preference for a greater turnaround. Who explains the result? That there means that that was a preference for having the specialist explain the result and not a local treating team. Then we went to the likelihoods that the test would change treatment, and all but the second one of these was significant, and overall it had the right kind of shape, so it increased. So there's a preference for a test which increases your likelihood that you would change treatment. And the assumption is that you're changing treatment to something that's better for you, more targeted for you. And then the length of time explaining the test, only one of these was significant, and that was 5 minutes compared to, I think the alternative was 20 minutes. So that would suggest whether you have a 10-minute consultation versus whether you have a 20-minute consultation, it doesn't really matter. But if you have a 5-minute consultation versus a 20-minute consultation with someone explaining the test, then actually there is something in that extra time. Okay, those mean nothing to most people. I hate interpreting regression results. I love getting them because it means I've solved it. I could walk away from my computer, but I don't like interpreting them. So what we've done is then looked at the willingness to pay. And so the willingness to pay, we can also nicely put willingness to pay on bar charts as well. And so we can do things like show that that in this sample, the public were willing to pay $550 to receive the results in 2 weeks rather than in 6 weeks. Okay, so there's a strong preference for that quick turnaround. Likewise, they are willing to pay $220 to have a specialist explain the test rather than have a local oncologist explain the test. We also looked at, because we purposely sampled for those with own experience, we then did an interaction and looked at to see, you know, if you interact own experience with these covariates, then what do you get? And we actually find that there's no independent effect. So even if you're bringing in some experience of having cancer or an experience of a family member, it's not necessarily changing the way that you would make these trade-offs between the different attributes, which is kind of interesting. And I think that will flow through when we subsequently look at the patients who are experiencing it, whether there's a difference there. So a further thing we did was we looked at dominance. Okay, so this can raise a red flag. Just my attempt at doing some clip art. And so we looked at the patterns of choice decisions to just see if there was any that were dominant. So a responder was considered to be dominant. If they had a preference for a particular attribute, then they always chose the highest or the lowest one. And then these are the red flag because they violate the assumption of compensatory decision making, which means that, you know, you should be able to trade off and compensate for an improvement in another attribute. And it would mean that your marginal MRS would have no meaning. So when we looked at that, this is effectively trying to understand of, you know, who answered what and which questions, given what they were faced with, you know, what was their ultimate choice. We find that 28% in cost are preferring the ones all the time with the lowest cost. For change, we find that there's 15% who are preferring the ones which always have the greatest change in their treatment. And there's 11%, so, you know, in the change, the time, and the explain, you've got 12 options where you could have, you could prefer the best situation. And so anybody who picked it 10, 11, or 12 times, then that was 11% of the time. And for explaining, it was only 4%. So I should have explained at the start there, the cost one in this top left hand, there was only 6 times they could have chosen the best, and that was because in some of the choices, cost was the same, you know, so they always faced the same cost, and that was just the way the design came out. So they only had the chance of picking the best 6 times out of 12. And so what does it mean? It means that for time and explaining, so the amount of time you spend with your oncologist and who explains it to you, then there's generally non-dominant preferences. There's stronger evidence definitely of a cost preference, and I would expect, and I need to look at the literature here, that's possibly always the case with the cost. And I think that's because that's also something that most people face. You know, people pay for things every day. Whether they're choosing between different effectiveness levels on tests is not something they do every day. And then on the change attribute. How does this align with what else we've done in the survey? So if you recall, just on the side there, that was the ranking when we asked people to rank. So the most important to them was cost. And so yes, that aligns because that's the kind of dominant. But then they said it was time to receive the test. And in fact, we've found that that's a non-dominant preference. So there is something going on that when you face the combinations of attributes and levels, that it's changing. So the fact that time was ranked higher than change is kind of counter to this. And I should have said, I don't know if I did, when we did the pilot, we actually found there was some dominant preferences coming through in the pilot. So we actually did change the design to try and overcome those dominants. So we've already kind of addressed the design here in this sense. And I suspect, you know, if we were going to do this again, we could change the design again, but then, you know, then we might still find it. So, you know, how many times do you keep changing the design? So this is kind of my favorite bit when you do kind of preference solicitation tasks, is you just ask them what they're doing. So we had an open kind of box at the end of the survey. We got some really insightful things. You know, we get the things that you don't like, which is, this is really hard, or, you know, I just picked everything on the right, you know, which is kind of useful. You can chuck them out if you want to. But some kind of insight, some kind of attributes, you know, and so this, remember, this is a general public here. So advanced cancers are often not curable. Great, they read the blurb we had at the start. Hence, any minor considerations such as time to receive the results would not be given much weight, which is kind of interesting. So they were almost saying, well, it's incurable, so whether I receive the results in 2 weeks or 6 weeks doesn't really mean much to me. But maybe they weren't thinking of the changes in quality of life that could come about from a changing in treatment. Cost was the main factor for an aged pensioner, and getting treatment ASAP is imperative as well. So they're reflecting on some of their own demographics. It would be difficult to be objective if it was definitely my cancer prognosis in question, which is kind of interesting. It comes back to some of the work that I know that's going on here, which is about the kind of shared decision making. You know, so how does a clinician sit down with a patient and go through these options and get them to make an informed choice? And then the last point that I've highlighted is the factors that I looked at each time changed with each question. Yep, that was the design of the DCE. So it's great to know that the DCE is sucking them into exposing them to different information each time. Sometimes it's the length of time, had to wait for the results. Other times it was the likelihood of change in treatment. There was no one factor that affected my decision. So that's kind of neat. You think, you know, great, the DCE works as, you know, kind of theory expects. Then we had some people comment on the questionnaire design. You know, they could comment as they wanted. You know, it was not simple to work with and had many options and changes and methods for answering. Again, that's the design for the survey. So it doesn't take into account that everybody has a choice, not a choice out of 2 possible answers, but the answer might not be any of the ones given in the survey. Okay, so, you know, it could have been more complex if we'd given, you know, more choices in terms, but, you know, we didn't want to go down that route. And then a survey that really gets you thinking. I feel the best treatment plans with the best results would come from a medical specialist, which is kind of interesting, which kind of slaps in the face of shared decision making again. You know, I'll just leave it up to my oncologist to tell me, you know, what they think is best. So the last bit that I've done here is, and then I'll welcome your thoughts actually about, you know, what do we do with this and what do I do more generally with the broader project. As we looked at willingness to pay of different genomic testing scenarios. So the idea of the willingness to pay is you can actually sum them up. And so what we did is if you think back, I'll just spin back and give, if you think back to those kind of willingness to pay for each of those attributes, then if you give the results to someone in 2 weeks and they're explained by a specialist in a 15-minute consultation, and the test has a 25% chance that you'd be changing your treatment, then the willingness to pay for that, the sum of the willingness to pay, is $1,092. Whereas a different scenario, which is where the results are returned in 6 weeks by local oncologists in a 20-minute consultation, and the test has its 15% chance of changing treatment, then that's $428, the willingness to pay for that kind of scenario. And so I guess ultimately what you can do is you can take that and you can compare it to, so now the health system has to think about the cost of designing a service that does that. Okay, so if we had a service where we could have a 2 or a 6 week turnaround, so you've got to think about, you know, how you resource your pathology system, your network. If we have specialists versus local oncologists, so do we put the idea of putting, I guess, more specialists into, you know, more kind of general hospitals, or maybe somehow having everybody come to a specialist hospital? That would require, I guess, potentially more resources of oncologists in that specialist hospital. And then different consultation times. So if you're consulting for 20 minutes versus consulting for 5 minutes, then you'd be seeing less patients. And then work out, you know, what is that staffing resource and how much does that cost? And then bringing into that a test, which is still a hypothetical test that they don't know, you know, what the test is currently. They are putting them through a test at the moment, a panel. and then working out the different effectiveness levels of that test. Then ultimately they could work out if the benefits are greater than the costs, and that's a reason for implementing the genomic testing. Okay, that's the theory. So I actually have a question as to whether that would ever be the case. So how is evidence going to be used? But I think that's one of the reasons we went down this kind of willingness to pay route. I should have said at the start. So with the patients who are doing the DCE, we're also collecting their demographics, but we're also getting them to fill in the EQ5D and also I think the EORTC-C20, which is a generic kind of cancer measure. That also allows you to get preference-based, and so you'll be able to produce qualities. But the strange thing here is that we're trying to get people to give preferences or give utility improvements for a test, not for the treatment change that will result from the test. So we actually initially thought we're never going to see, why would your activities of daily living, why would your pain, why would you see an improvement in that? Because you've had a test. So we immediately thought that actually the current instruments that we have are never going to be able to pick up that health-related quality of life improvement that you get from the test, because the test, all the test does is gives you more information. It might give you more information. It might put you at ease. It might make you more anxious. We didn't actually necessarily think that the current instruments would do that, so which is one of the reasons we also decided to put in a preference solicitation study as well. I'm not sure what will happen if the preference solicitation study gives different results, which it probably will from the health-related quality of life instruments when we go down that kind of route. And this is something that James Buchanan is looking at. When you try and work out the cost effectiveness of a test by doing cost per quality, you need to make sure, or even if you're doing the test which comes with an accompanying treatment, how do you separate out the two? And those are two often, unless they're a companion diagnostic, those are two separate decisions that are often made. And in the Australian context, I should have said at the start, these are actually two different decision-making bodies that make these. So there's the MSAC, the probably getting it wrong, Medical Services Advisory Committee would make a decision about genomic testing, whereas it would be something like PBAC, the Pharmaceutical Benefits Advisory Committee, that would make this decision about the treatment. Okay, they do meet together, but they're two different decision-making bodies. So in that sense, the decision-making itself kind of lends itself to separating these two out. So there's some possible steps I could do, and I'd welcome your thoughts on these, because I'm kind of I'm definitely a no, depending on how much time I've got in the day. I'm a yes. Most of the time I'm a maybe on whether we should do these, whether I should do them. Every time I try to ask James to do it, he just thinks I need to learn to do it. So whether I should look at preference heterogeneity by going perhaps down the route of different functional forms, or to be honest, the current functional form took so long to solve that I don't think a new functional form is going to add any value, just take away my time. And of course it is, and I should say it's not time that you're not doing anything else. So most of the time I was sleeping when these were running. So I'd set them running at night time, and then I'd wake up in the morning, to the results, until I realized that when my laptop was going to sleep, Stata also goes to sleep. So that's just something. So I had to figure that out after 2 nights. And then maybe understanding if we wanted to look at some latent cast models to do this. There's something about whether we should explore the role of kind of income, particularly because there's a private public kind of mixed system. But I'm trying to understand, what value that would give in terms of implementing a decision. And then there might be something, because we have information on the urban or rural location. So are the preferences different, depending on where you live? And that might be something that we perhaps could explore, because that potentially could inform a kind of a federal or a state decision as to where to put some more information, to put some more funding. So to summarize, and then I have questions for you. Cost, timeliness, and expertise / location, and likelihood of changing treatment identified as attributes of sequencing that are most valuable. Okay, so The results will ultimately be compared with what the patients think. So the patients who are undergoing these they're actually undergoing sequencing. So the novelty of that study is we are giving the DCE to patients pre the test. They're getting the test, they're going to get the test results, and then we're going to give them the DCE afterwards to see if actually, and then loop it back in the analysis to see if an actionable mutation or a change in their treatment has changed their preferences for a test. It does obviously bring up this idea of societal preferences versus patient preferences, which I'm sure we'll have a discussion about. And then I think that the willingness to pay estimates can inform kind of adoption decisions. I mean, I know that's the case, but I'm not sure if they've ever been done. Which kind of brings me to where I kind of turn it around for the work in progress idea to think about what your thoughts are on this. So I've posed some further analyses, and I'd really welcome, if you think I should do some more. One of the questions is, how do we do the cost-benefit analysis? So at some point, we'll need to sum up, I guess, well, either need to sum up the willingness to pay, so you can compare it to the total cost of delivering the service, or you can work out the average cost of delivering the service and then compare it with the average willingness to pay. Is that how it's normally done? And then how is any of this translated to clinicians and policymakers? So I saw somebody here in scrubs, which means that you actually do work with patients. And so it would be interesting to see, how do we translate these health economics concepts to making sure that they do inform decisions, at the coalface, as I would call it. And then to come back to the idea of kind of patients versus public preferences. So just because we're able to do this survey quickly means we've got public preferences already, but I'm very nervous of putting them out there to potentially inform something that still hasn't been tested with the public, with the patients yet. And so there's kind of a sequencing issue there. So at what point do I start to engage if we still don't know what patients' preferences are on these? And then just quickly, some acknowledgements. So clearly I've got to acknowledge the general public, although we did pay them. And I have to thank some colleagues who we didn't pay. I think I might have given them a chocolate bar for piloting a previous version. And then obviously the Melbourne Genomic Health Alliance have funded it. And that's all of the hospitals and educational institutions that are involved, and the state government is ultimately the big sponsor of this. And so notably, the Melbourne Genomic Health Alliance would have liked to last month, although I promised it to them after my long flight back on Sunday, the report from this, because they need to show their funders that it's worth kind of rolling this out some more, which is a little bit that kind of makes me nervous, because it's great generating evidence, making statements, but even when I sat on a decision-making committee, I was always nervous that this had implications more wider than just my own academic CV. Yeah, okay, so thank you very much.